Welcome back to the deep dive. Today we're doing a really focused clinical journey through the demanding world of obstetrics and gynecology. And this deep dive is really built for you, the sharp, high-yield learner. Maybe you're prepping for a Viva or sitting for a board exam, or you just need to refresh those essential clinical reflexes.
It's so important to stay sharp.
It really is. Okay, let's unpack this. Our foundation today is a real cornerstone text for practical readiness. That is Bedside Clinics and Viva-Voce in Obstetrics and Gynecology. We're using the 6th edition.
A classic.
It is. And the book's great mission is to close that, that often nerve-wracking gap between knowing theory in a lecture hall and then applying it accurately when the patient is right there in front of you.
And that gap can feel enormous in Obgyn, which is why systemization is just everything.
Absolutely.
Our mission today is all about synthesis. We're taking that entire high-yield practical toolkit from the history and physical exam all the way to managing acute emergencies and boiling it down into clear, actionable frameworks.
It's about getting past just memorizing facts.
Exactly. We want you to be able to manage a patient systematically, to think critically when you're under pressure.
Okay, so the starting point for that systematic practice, the bedrock of everything, has to be the hands-on assessment.
Couldn't agree more.
We need to establish a flawless clinical toolkit. So let's jump straight into section 1, mastering the clinical foundation.
Just do it.
When you meet a patient, the initial history isn't just, a collection of facts. It's a clinical narrative.
It tells a story.
Right. And in obstetrics, that narrative needs to be distilled instantly into a concise summary of all her previous pregnancies. The source material emphasizes 5 crucial metrics, the essential shorthand, really.
The 5-point summary. Every clinician needs it at their fingertips.
So that's CREVITA, the total number of pregnancies regardless of the outcome.
Yep.
Then PARA, the number of deliveries past viability, so usually 20 weeks.
Right. And then you have miscarriage, MTP, medical termination of pregnancy, and finally, the most important outcome, living issue, the number of living children.
That 5-point summary gives you an immediate risk profile. It tells you so much in just a few seconds.
It does, but we can't skip the menstrual details either. It's not just about the last menstrual period. You have to capture the age of menarche, the pattern, cycle length, duration, flow.
Those details are what help you distinguish physiological from pathological bleeding.
Throughout her entire life, exactly. And of course, that LMP is crucial for determining the expected date of delivery, the EDD. We all learned Nagel's formula.
Oh yes, add 7 days, add 9 months to the LMP. But in a modern clinic, how often do you really rely solely on that formula?
That's a really excellent point. Nagel's formula is the traditional baseline. You absolutely have to know how to calculate it for an exam, but it assumes a perfect 28-day cycle and that the patient remembers the date perfectly.
Which isn't always the case.
Not at all. So if we're talking about quality of care, a first trimester ultrasound is far, far more accurate for dating. It really should be the gold standard, especially if the LMP is uncertain.
Agreed. Okay, moving from history to the physical examination, let's focus on what you see first on inspection. What visual cues instantly tell you about the progression of the pregnancy?
Well, when you inspect the abdomen, you're looking for confirmation. You're observing the uterine shape. Is it ovoid, like you'd expect? And the contour, is it smooth? Or are there any irregularities, any notches that might suggest an abnormal presentation?
And then you have the classic skin changes.
Right. The linea nigra, that dark line down the midline, and the striae gravidarum, and the stretch marks. These are physiological markers, not pathology, but they confirm those systemic hormonal changes are happening.
And you'd also know things like an inverted umbilicus or more prominent veins.
Yes, from the increased blood volume. All part of the picture.
Okay, now for the hands-on skill that really defines an antenatal exam, external palpation. If a learner's in their practical exam, they must have mastered the 4 Leopold's maneuvers.
Oh, absolutely. These are the essential steps for figuring out presentation, position, and engagement. The key is remembering the specific objective for each one.
Let's run through them. Number 1.
The first Leopold, or the fundal grip. This assesses what part of the fetus is in the fundus, the top of the uterus. Usually it's the softer, bulkier breech.
Then the second Leopold, the lateral grip.
Yeah, the lateral or umbilical grip. This is to identify the fetal back versus the small parts, which tells you the fetal position is the back on the left or the right.
Okay, third is Pollux grip.
Yep. This one is all about the presenting part. It confirms what's over the pelvic inlet head or breech and whether it's ballotable, meaning it's still floating, or if it's fixed.
And the fourth, the pelvic grip. This one seems the most crucial for predicting labor.
It is, especially in a first pregnancy. The fourth Leopold determines the degree of engagement. It tells you just how much of the fetal head has descended past the pelvic brim.
So that fourth maneuver is really the key takeaway for predicting a successful vaginal delivery.
Exactly.
Now, let's quickly contrast that with a related exam, the normal puerperium. It's structurally very different from the antenatal case.
Completely different. The puerperium is that 6-week period after childbirth. Here, you're not doing obstetric grips or listening for fetal heart sounds.
The focus shifts entirely.
It shifts to confirming normal physiological recovery, primarily uterine involution. The key timings to remember are that the uterus becomes a pelvic organ again, so no longer palpable abdominally by about 2 weeks postpartum.
And all pelvic organs.
They should be completely back to their non-pregnant state by 6 weeks postpartum. Any delay in that involution is a red flag.
That's an excellent framework.
Yeah.
And it brings us smoothly into our next phase. We've done the hands-on exam, but clinical medicine is also about the data you use to manage risk.
Especially when it comes to fetal well-being.
Exactly. Let's move to section 2. Fetal surveillance and diagnostic protocols.
Right.
So what's the foundational stack? The absolute must-have list of initial labs that every pregnant woman should get.
The routine workup. So blood work is extensive. Hemoglobin percentage, HB%, is paramount because of the anemia risk. We need ABO and RH grouping to check for RH incompatibility. Then VDRL for syphilis screening, blood glucose. And a routine urine exam, checking for protein, sugar, pus cells. Ruling out preeclampsia, diabetes, UTIs.
And cervical cytology screening is now standard of care too.
Yes, early on.
So when do we go beyond that routine stack? What special investigations come into play for, say, high-risk scenarios?
Those are usually triggered by risk factors or patient age. So serological tests for things like rubella, hepatitis B, HIV, and you always have to stress with informed consent.
Oh, yeah.
We also use prenatal screens like maternal serum alpha-fetoprotein, the MSAFP, or the triple test for risks of neural tube defects or chromosomal anomalies. And of course, targeted ultrasounds. The first trimester dating scan and the big anomaly scan around 18 to 20 weeks.
Now let's dive into late pregnancy. Assessing fetal well-being here requires really careful interpretation of biophysical data. The first line is often the kick count, the DFMCR.
The daily fetal movement counting record, yes. It's a simple, high-yield subjective tool. A count of more than 10 movements in 12 hours is considered satisfactory.
And what's the specific method mentioned in the source?
The method detailed is to count kicks for 1 hour each in the morning, afternoon, and night. Then you multiply that total by 4 to get a good estimate for the 12-hour period.
Okay, but if a patient calls you and says, I've only felt 8 kicks in 12 hours, what's the next clinical move? You don't just tell her to keep counting, right?
No, absolutely not. That's where our data triage system kicks in. If the DFMCR is compromised, you escalate immediately to objective screening, which is usually the non-stress test, or NST.
But what makes an NST reactive?
An NST is reactive if you see 2 or more fetal heart rate accelerations with adequate amplitude and duration within a 20-minute window. A reactive NST is very, very reassuring.
And if it's non-reactive or maybe equivocal, we often move to the fetal biophysical profile, the FBP. What does that test aggregate?
The FDP is a comprehensive score. It combines 5 different parameters, each scored as 0 or 2. It includes the NST we just mentioned, fetal breathing movements, gross body movements, fetal muscle tone, and the amniotic fluid volume.
What's the threshold for concern?
A score of 8 out of 10 is great, indicates a healthy fetus. A score of 6 or below. That often prompts either intervention or at least very close observation.
And finally, we have advanced imaging. The Doppler ultrasound, specifically of the umbilical artery, this really tells us about placental efficiency.
Doppler velocimetry is critical for diagnosing placental insufficiency. When you see reduced, absent, or, and this is the most critical, reverse diastolic flow in the umbilical artery, that is an ominous sign.
Ominous how? What's happening physiologically?
It means the resistance in the placenta is so high that the fetus is actually trying to steal blood back from the umbilical circulation. It's a sign of severe, immediate stress. That finding requires urgent action.
Wow, that deep dive into diagnostics is a perfect transition to Section 3, high-risk management and scar evaluation. One of the highest stakes scenarios we see is managing a pregnancy after a C-section, specifically vaginal birth after cesarean, or VBAC.
VBAC is a huge clinical and ethical topic. The benefits for the patient are powerful. Less morbidity than a repeat C-section, faster recovery, high maternal satisfaction. But there's one key risk that dictates everything:
Uterine rupture.
uterine rupture. And it's crucial for learners to know the true incidence. In a highly selective case, monitored carefully in a tertiary center, the risk is typically less than 1%.
But it's catastrophic when it happens.
Always.
Speaking of rupture, we need to clarify a really important distinction. Scar rupture versus dehiscence. They get confused a lot.
They're completely different things clinically. A rupture is a complete separation of all uterine muscle layers. The uterine cavity is now communicating with the abdominal cavity. This means severe acute hemorrhage and fetal distress. It's an emergency.
And dehiscence.
A dehiscence is more like a uterine window. It's a defect in the muscle, but the overlying peritoneum stays intact. So there's minimal or no hemorrhage. It's usually asymptomatic, and you often find it incidentally during a subsequent C-section.
So the danger is different. It's not acute hemorrhage.
No, the high-stakes danger of dehiscence is that it can be missed entirely until the next pregnancy, which really complicates future management.
Shifting gears to a massive public health issue, anemia in pregnancy. The source highlights some stark prevalence rates, particularly in places like India, where over 50% of pregnant women might be anemic.
It's a huge problem. And anemia isn't just about fatigue, it's a massive cardiac risk factor. The volume shifts and stress of pregnancy can push an anemic patient into acute cardiac failure.
And there are specific times of greatest risk.
Yes, clinicians have to memorize the 4 times when the risk of cardiac failure is greatest. First, around 30 to 32 weeks gestation when plasma volume peaks.
Second,
During labor from the exertion. Third, immediately after delivery when all that placental blood gets shunted back into her circulation. And fourth, anytime in the puerperium due to infection or more blood loss.
that 30-32 week mark is such a critical moment for assessment. Okay, let's move to another acute topic, eclampsia. Magnesium sulfate is the drug of choice.
It is. Text-MGSO4 is so effective because it's a membrane stabilizer and a neuroprotector. It prevents subsequent seizure fits. But it has a low therapeutic index.
Meaning the line between helpful and toxic is very narrow.
Exactly. Which is why strict monitoring is mandatory. You have to constantly monitor 3 vital clinical signs. First, the presence of knee jerks. If they disappear, that's a sign of CNS depression.
Second is urine output.
Yes, ensuring urine output is over 30 milliliters per hour. The kidneys excrete magnesium, so poor output leads to rapid toxicity. And third, the respiration rate must be over 14 per minute. Respiratory depression is the most immediate life-threatening sign of an overdose.
And if those signs start to vanish?
You stop the infusion immediately and you give the antidote, injection calcium gluconate, specifically 10 milliliters of a 10% solution, given as a slow IV push.
That detailed application of knowledge leads us right to our final section, operative obstetrics and essential pharmacology.
Right.
Let's quickly frame the operative procedures discussed in the text.
Operative obstetrics really covers the whole gamut of intervention. You have procedures to terminate a pregnancy, like dilatation and evacuation DNE, or suction evacuation.
Then procedures to assist delivery.
Right, like an episiotomy, forceps delivery, or ventouse, which is a vacuum delivery, and of course the primary abdominal delivery, the cesarean section, or LSCS.
The source also mentions the destructive operations.
It does. Things like craniotomy or evisceration. They're rarely performed today, but are important to know about historically and structurally.
When we prescribe anything, safety is paramount. The FDA fetal risk categories provide that essential framework. Let's just focus on the 2 extremes, Category A and Category X.
Category A is the safest. No fetal risk has been shown in well-controlled human studies. You can prescribe those with confidence. Category X is the danger zone.
Absolutely contraindicated.
Absolutely. The proven fetal risks clearly outweigh any possible benefit, and the source lists clear examples: alcohol, ACE inhibitors, isotretinoin,
The acne medication.
a potent teratogen, also methotrexate, valproic acid, mifepristone, and radioactive iodine. No compromises there.
Let's profile 2 critical drugs we see constantly. Starting with the first choice for pregnancy-induced hypertension, methyl-dopa.
Methyl-dopa is the first choice because its safety profile for both mother and fetus is just so well established over decades. Its mechanism is a central and peripheral anti-adrenergic action that lowers blood pressure without really compromising placental blood flow.
And let's just reinforce the role of our earlier topic, magnesium sulfate.
We reinforce its role not just in acute management, but also in prevention. It remains the essential choice, that key membrane stabilizer and neuroprotector for managing eclampsia and preventing more seizures.
This has been such a systematic, high-yield deep dive. from that 5-point history summary and mastering Leopold's maneuvers all the way to interpreting a Doppler report.
I think the final takeaway for any learner is that complexity in Obgyn demands integrated skills. You have to know the facts, yes, but also the high-stakes context. You need communication, decision-making.
Critical evaluation.
Yes, especially when you're managing complex variables like a placental abnormality, say, identifying a placenta sexcenteriata, which carries a huge risk of postpartum hemorrhage, or understanding why monochorionic twins have such a higher complication rate than dichorionic twins.
That brings us to our final exercise. A thought for you to carry forward, building directly on that connection between postpartum physiology and management we talked about earlier.
Okay.
All right, here's a short exercise based on what we just covered. A woman is exclusively breastfeeding her baby, and because of that, she's amenorrheic. She's not having periods. What is the fundamental hormonal mechanism that causes this amenorrhea?
And practically speaking,
What is the recommended time frame to start contraception for her compared to a woman who is not lactating? This is knowledge that goes from basic science right into direct, crucial patient counseling.
think about the suppression pathway involved there. That mechanism is what governs lactational amenorrhea, but it's an imperfect contraceptive, and that's the clinical dilemma you have to address.
Keep that clinical knowledge sharp, and we'll catch you on the next deep dive.